afternoon. Welcome to Ask the Docs, a Fertility Institute of Hawaii live stream. This month, our topic is optimizing natural fertility. My name is Dr. Carmone.
I'm Dr. Goulet.
And we also hopefully will have Dr. Frederelli joining us. I think he's having some technical difficulties, but we'll add him in as soon as I see his face come on. Oh, looks like he might be joining us. Let's see if this is going to work for him. Okay, Dr. Frederelli, we are live. I just started the introductions. This is Dr. Frederelli. Thanks for joining us today. We've got a lot of really good information to share. So what do you think we should start with? Dr. Frederelli, did you have a starting point? I have some ideas, but.
Well, I think, obviously we're going to talk about optimizing, natural fertility today. So maybe talk about at first, when you're trying to optimize fertility, what should you be doing in order to, or before you actually come to a reproductive endocrinologist or go see your provider?
Yeah, why don't we go ahead and start with that? So people always think about trying to conceive and what that means. We can kind of go through some best practices for that. And also do keep in mind that most cases of difficulty conceiving are probably not because of timing issues. Some are, if intercourse is very infrequent or if there's some other issues happening, if menstrual cycles are very abnormal. But oftentimes people tend to be overly concerned about timing. And that's because the fertility window is longer than people might think. Okay, so it is the 6 days prior to ovulation that is the most fertile time. So what that means is that if a woman has a regular cycle, about 28 days or so, then she's typically ovulating around day 14 or so. And so two people can have unprotected sex around day 10, 12, 14, okay? Those are really the most fertile times to be having intercourse. The literature suggests that having intercourse every day or every other day are very similar to in terms of success rates. Okay, for men who have normal semen parameters, there's no reason to hold back and have longer intervals between intercourse. Okay, sex every day or every other day are the same, but there's also no real significant reason to have intercourse every day. At ovulation, post-ovulation, the chance for conceiving does decline significantly. So it is good to have sperm where it needs to be prior to ovulation. This type of timing can be difficult in women who have irregular cycles because they're kind of unsure about when exactly they're ovulating, but there are some techniques that can be utilized. I don't know if Dr. Goulet, maybe you can go through some techniques, some ways to figure out when you are ovulating.
Right. So typically what we say varies is the period of time up to ovulation. After you ovulate, it's a consistent and routine 14 days. So if you count back, if you're tracking your cycles using a calendar or a diary or even an app, if you can count back 14 days before your period, and that's typically when you are ovulating. Women who are doing things like tracking their basal body temperatures, you have to buy a special thermometer that's extra precise for doing that, helps you learn about what your ovulation day is retrospectively in the past, because by the time you ovulate or by the time you get that spike in your temperature in this cycle, you've already ovulated and that fertile window has already passed. But it can be interesting to learn about what your metabolism and your body temperature is doing throughout your cycle. Let's see here. I don't know. I think a lot of people are using a lot more apps these days because I see people coming in and the apps are predicting for them when their fertile window is. And it's really neat what technology can do. And there's those devices that you can even download and buy. If you're having a pretty consistent period, 26 to 31 days-ish, once a month, Ovulation predictor kits can be helpful in those individuals, and typically we recommend starting those on cycles day 9 or 10. If you're using the digital one, the digital chips are not as smart as we are. They can get thrown off if you're using them more than once a day. So follow the instructions on your device, because each device is engineered a little bit differently.
And it's only as good as the programming that has gone into it as well. So some may be more accurate than others. There's the option to use LH predictor kits over the counter, which look for the LH surge that happens prior to ovulation. Those are nice because they will tell you when you're going to ovulate, whereas the basal body temperature, it increases when you've already ovulated. So as I mentioned before, it's better to have sperm where it needs to be prior to that ovulation point. So the LH predictor kits can be good. They can also be pretty finicky. Some people, for example, people have polycystic ovary syndrome, even when they are ovulating regularly, their LHs are naturally a little bit higher than people who don't have polycystic ovary syndrome, or people who have an issue with their ovarian reserve. Sometimes those patients can have elevated LHs, and so the kits don't work very well for them. Obviously, as fertility doctors, we can certainly help monitor cycles, but if you're kind of trying at home, I think that the key thing that patients don't realize is that you really don't, you know, this is helpful for people who are having trouble and who are concerned and anxious and concerned about the timing. But if you are having regular menstrual cycles and you're having regular intercourse around the time of ovulation, it is not really necessary and has not been shown to improve outcomes to know that you're ovulating if you're going to have sex anyway. Like if you're going to have sex anyway that day, then it doesn't help to know that you're ovulating. You should get pregnant. So I do think that sometimes, sorry, I'm just going way out.
No,
here
I know.
now.
I pulled in the basal body temperature. And
yeah,
the
like
case,
this is, but I do think that, John's laughing. I think that it is not, you know, that the utility of these apps is really overstated and oftentimes creates more anxiety, right? Because then you feel like you have to have sex on a certain day. It really kills the romance. And so it's oftentimes unnecessary for patients. And especially if patients are having a lot of trouble, then seeing a fertility specialist is going to be more helpful than, you know, using LH predictor kits, I think.
There's a couple of other preconception things that I wanted to touch on as you are trying to conceive, and that's regarding pills, over-the-counter, prescription medications that you may or may not be on that you need to think about as you are trying to conceive. There are a lot of things that are contraindicated in pregnancy, such as retinol, which you can find in Accutane, as well as some of the over-the-counter face products. So those are things that we recommend you stay away from. We do recommend that every woman trying to conceive, or every woman of childbearing age, be on a prenatal vitamin. And that's good for not just your baby's nutrition, but your nutrition as well, and can help stave off some of the other complications in pregnancy, like severe nausea and vomiting. There are some other supplements that, if you're a supplement kind of person, we do suggest could be helpful. We don't think they're harmful, and those are things like CoQ10 or omega-3s, but definitely we want to see that you're on something that has some supplemental folic acid, also known as folate or vitamin B9. Last but not least, if you're on any prescription meds and you're trying to conceive, I do recommend you go over those medications with your primary care provider, because some of those can also be detrimental to the development of the baby. Things such certain high blood pressure medicines, certain dermatology medicines, we know for sure aren't good, and there's often a safe alternative. Most people say that, oh, I'll just stop everything as soon as I know I'm pregnant. That doesn't always work out well either, because there are some medications that we want you to continue and maybe even go up on, such as thyroid medicine like levothyroxine.
Yeah, I think let's just go back to sex for a second.
Okay. Can I jump in here before the sex? Can I jump in here, I guess?
Yes. Okay, fine.
So I just to kind of reiterate a little bit, I think that everyone needs to realize that time to conception really is going to vary for patients, and it's going to change with age. And so if you're younger than 35 and and everything seems to be normal, then the recommendation is you try for about a year, and if you're not having success, then you contact your provider. For patients who are older than 35, the clock is ticking, and it's a little bit more incumbent upon you to seek help quicker. So after about 6 months, if you're not successful, you should seek some assistance or guidance. And certainly, if you know that there's a problem, you should seek assistance immediately. And then going back to, I guess, when we were talking about the fertile window, I think certainly it's studies have shown that you can get pregnant with intercourse a week before ovulation, and even up to like 5 days after ovulation. But the peak time, if you had to pick one day to have intercourse for the sperm to be there prior to ovulation, the peak fecundity, at least most studies have shown, is about 2 days prior to ovulation. The problem with all these studies, you don't really know exactly when ovulation is occurring, so it's kind of guessing, and that's part of the ovulation predictor kits too. And that's what I was going to ask you guys about that. Ovulation predictor kits, the apps that are out there, they're predicting ovulation. They're not confirming ovulation, right? So they're showing, like the ovulation predictor kit, the urine kit is showing that your LH is going up. That doesn't necessarily mean you're ovulated. So it just tells you that the hormone levels are going in the right direction prior to ovulation. And for most women, they will ovulate, but not everybody. And so or you might not have a good ovulation, and so you may not be able to get pregnant because there's an ovulation disorder or ovulation issue. And likewise, regular menstrual cycles, that the apps, and you guys can maybe correct me if I'm wrong, but the apps are really just looking at your menstrual cycle. And if you have regular menstrual cycles, saying, okay, well, based on menstrual cycle, this is when you should be ovulating. But just because you have regular menstrual cycles doesn't mean you ovulate. And so there can be issues there where you just need to look to see if it confirm that you are ovulating. And then there are certainly natural things that you can do, looking at cervical mucus. Libido typically will increase for women at the time of ovulation because it's hormonal. And obviously, sometimes you can feel what we call Mittelsmurt's pain, where you can actually feel the ovulation event around the middle of the month, around the 14th day or so of the menstrual cycle. But what are your thoughts, Dr. Carmona and Dr. Goulet, about the apps that are out there?
I think you're right. I mean, most of the apps are just calendars. They're kind of calculating based on menstrual cycle length. I mean, most women who have regular periods, although you meant, and I agree, obviously not everybody who has bleeding is ovulating, but most women, if you have regular periods, most of the time you are ovulating, most likely. And I think that the apps are very useful for those patients, because you can just easily open it up and see if you're, you typically ovulate around day 14 or so, then the app's going to tell you your fertile window. But it's obviously problematic for people who have irregular cycles, because the app's not going to be able to predict, in any kind of useful way. There are some devices, though, which are looking at, body temperature. And I think that is also helpful, because that's kind of confirming that you're ovulating, and kind of will base calculations of ovulation based on that. So there are some more advanced things, but nothing can really be, there's a limit to how accurate I think those are, and how necessary they are. Since, like I said, if you're having sex anyway, it doesn't matter how many apps you have open or have recorded. Dr. Fraterelli, what about position? Does that matter? Like what sexual position you're in?
No, the sperm is going to be deposited in, at the level of the cervix with intercourse, and regardless of the position, it's going to be able to get through the cervix. The mucus of the, it interacts with the cervical mucus, and the cervical mucus will kind of draw it into the cervix and into the uterus, and so it doesn't matter what position you are in. There's no improved coital position that will improve pregnancy. At least it's been found as of yet.
As of now, is there? You have to have your
ongoing studies, I think.
Do you have to have your legs up or anything like that afterwards?
Prop your back up underneath the pillow.
Nothing like that. All right. Okay. All right. I just wanted to go over that.
And I guess for Dr. Clay, what about lubricants that I think that are out there that people oftentimes will use? And sometimes, that they're hindering their ability to get pregnant with some of these lubricants. What would you suggest that would be safe and what to stay away from?
They market a lubricant called Preseed that has been tested and shown that it does not interfere or reduce sperm viability. So that is something that we do recommend. Some of the more common over-the-counter lubricants like KY and whatnot, those can reduce sperm numbers. So if you're concerned, certainly you can look at Preseed. Some individuals have mentioned using some natural oils, olive oil, coconut oil, those things as well, depends on the oil, can also interfere more than others with sperm numbers. So the Preseed's the safe way to go.
Also canola oil, by the way. So canola oil does not appear to harm sperm.
Correct, but other oils do.
Yes, no, other oils do. But I mean, canola oil is one of them that you can go for in the kitchen. If you need to. Yeah, so not every oil. So don't grab, whatever oil you have there, but the canola oil is okay. Yeah. What else? I guess we can talk a little bit about some lifestyle changes or lifestyle things that have been shown to diminish or improve fertility potential. What about smoking? Does anyone want to talk about that?
Well, in general, I tell most of my patients what a doctor would recommend for overall good health is probably good for you while you're trying to conceive and while you're pregnant. So common sense things like, quitting smoking is always recommended. We do know that nicotine use, whether that be through tobacco, smoking it, chewing it, or vaping, is detrimental to both conceiving as well as obstetrical pregnancy outcomes. So we do recommend you stop any nicotine use that you've got going. And if you are having difficulty, please speak up. There's lots of resources available with your fertility doctor or your PCP to help you choose a way that will make you successful in achieving that goal of quitting any nicotine use. Other stimulants such as caffeine may also have a detrimental effect if you're using it at high intake levels. And so typically we recommend you stick to less than 1 cup of coffee a day, which is about 200 milligrams for a Starbucks cup of coffee. So if you're ordering a venti 20 ounce, that's going to definitely be more than 200 milligrams of caffeine. So work on limiting your caffeine intake as well, but a little bit of caffeine is fine.
So most coffee on average is probably 60 to 100. So that's why limiting to, what is the typical recommendations of 1 caffeinated beverage or less is probably okay. But yeah, some of the, cold brews, nitro brews, some things, definitely energy drinks, things like that. Pre-workout, it's crazy how much caffeine some stuff has in it. So you do have to be careful, but a simple brewed cup will certainly contain less than that.
And, on that note, those energy drinks and those pre-workout supplements, caffeine isn't always listed as caffeine. And so you do have to be discerning with those ingredients. Things can sometimes disguise themselves as green tea extract or, cocoa bean tincture. I've seen random ingredients that is caffeine in disguise.
I think it's also important when you talk about smoking to realize that for women who smoke, menopause is typically going to be somewhere between 1 to 4 years earlier than women who aren't smoking. When you look at the data, there's also an increased risk of miscarrying for women who smoke compared to women who aren't smoking. Likewise, for caffeine, not only is the caffeine does it decrease fertility, it does increase your risk of miscarrying if you're over that 2 to 3 cup limit.
Yeah, and that there have been studies linking actually preconception caffeine intake to miscarriage risk as well. So that's something to really keep in mind when you're trying to conceive. And high caffeine intake has been shown to affect sperm function too. So that's one of the things to look out for men. And some of these lifestyle changes are so significant, or some of these lifestyle factors are so significant that insurance companies look at them prior to deciding whether or not they're going to cover. So in certain areas, insurance companies will require testing for nicotine. And if you test positive, you're not going to get coverage for in vitro fertilization because the success rate with IVF declines very significantly for people who are active smokers.
Now, tobacco is not
marijuana. I was going to say, yeah, I think you were going to start with that, Dr. Gilley. What about marijuana?
Yeah, there is not a lot of randomized, double-blinded controlled trials regarding that, but we don't think it's good for pregnancy or preconception. And that's not just, marijuana that's being smoked, but that also includes the edibles that you can find at dispensaries as well. And the THC products we think have a negative effect on preconception.
In terms of alcohol, okay, so there are two different things I think to keep in mind. One of the biggest issues with alcohol, and there was some controversy about this when this kind of people were abuzz about it a few years ago, but the concern is that there's no safe level of alcohol intake in early pregnancy. And so there's some concern that in early pregnancy that women who are trying to conceive shouldn't drink at all, because what if they, get pregnant and then have issues? And so while that makes some sense, I think in terms of fetal development, moderate or, small amounts of drinking don't seem to impact fertility when you're, trying to get pregnant. So I'm not really talking about the fetal development issue, but it's really not going to harm fertility potential or sperm if drinking moderately. High amounts of alcohol can really impact and blunt some of the response to your own gonadotropins. So it can cause issues with hormones, which in turn can affect ovulatory function and sperm function. But that's generally pretty high amounts of alcohol. And obviously, again, since we're trying to prepare you for pregnancy, we don't want you to be doing things that are not recommended in pregnancy. But small amounts of alcohol are probably not really harming sperm or egg function. What about BMI? What do you guys think about that?
BMI is always very difficult, right? Because we know what it does, but the problem is it's very difficult for some patients to lose weight, and I think that we always try to keep that in mind as we're discussing it with our patient. That doesn't mean that we can't give them the information, but mandating that they lose weight is very difficult because some patients just can't do it. But people who are underweight, so BMI is less than 19, and people who are obese, BMI greater than 35, do have increased fertility issues. It takes longer for them to get pregnant. There's more infertility. There's more miscarriages, and also there's more pregnancy complications for those patients. More so for the patients who are obese than the ones who are a little bit underweight, unless the patients who have very low BMIs aren't able to increase their BMI during pregnancy. And so that's one of the other things that we're always concerned about is high blood pressure, diabetes, all of the complications that can happen with pregnancy are going to be much more prevalent in women who are obese and pregnant?
Yeah, I also want to bring up questions, because there are some people have questions about bariatric surgery too, which has become really popular. And there's some concern that, you know, if you have bariatric surgery prior to pregnancy, that there can be issues with nutrition during pregnancy, et cetera. But it does appear, it's been studied numerous times now, it does appear that pregnancies after bariatric surgery, although there are some potential complications, do appear to be overall healthier when you look at large numbers than the patients, than their obese counterparts. Doing surgery to help improve weight loss in those who really have, you know, who have a very high BMI and who have trouble losing weight in any other way, can be helpful and can make for improved pregnancies. Whether or not that improves fertility is another question. And there aren't a ton of great data suggesting that necessarily improving weight is really going to improve your fertility outcomes. It'll improve the health of your pregnancy, but not necessarily make you more fertile. It may help your ovulation, your ovulatory function. That's true. It may help improve your hormone profile. So indirectly, those types of things may be improved, but it's not 100% that, you know, weight is the issue, and that if you lose the weight, you're going to fix it. And so that's why also sometimes I hesitate with patients who are overweight in, you know, recommending that they take off more time and really help improve because first of all, it might not help, but also they're going to be older. And so I kind of have to personalize their treatment plan to them, take into consideration their weight, their comorbidities. Do they have high blood pressure? Do they have diabetes? And their age.
Absolutely. And I think that, you know, preconception is a great time to assess what your weight and your BMI is, because throughout pregnancy, we are going to expect some more weight gain in general. And it's just going to be even more difficult to lose after the pregnancy. So anything you can do to optimize where you feel good about your body beforehand. We are concerned, you know, especially in the extremes when your BMI is, you know, reaching above and beyond, you know, 35, 40 and higher, you know, that can be a concern both for your health as well as for preconception fertility.
I'll ask, maybe I'll ask you, Dr. Carmon, if you were speaking to one of your relatives, and I ask this because of the pandemic right now and the COVID vaccine, and there obviously are patients that are concerned who are getting pregnant, who want to get pregnant, who may be pregnant. If you were speaking to a relative of yours, you know, what information would you give them about the vaccine currently?
So currently, all the organizations that we trust are recommending the vaccine, both prior to pregnancy and in pregnancy. There are no data suggesting that the vaccine in any way harms fertility or pregnancy. And now there have been some studies looking at this. There was one recently, I think it was in the New England Journal, which did document thus far the women who've been pregnant and who received the vaccine and did not show a difference in miscarriage or other comorbidities. And so I think it's much better to have a vaccine than to get COVID in pregnancy. So far, I think that COVID, initially the studies have showed that women who were pregnant did not necessarily have worse outcomes with COVID, but that may not continue to be the case with the Delta variant and other more serious variants as well. So I think that there really is no downside to getting the vaccine, and that goes for men as well. There was some concern about sperm function too, but it's I think that for for males as well. The data do suggest that there's more good than harm that comes out of receiving the vaccine. Yeah.
And flu season is just around the corner as well. And we expect rollout of those influenza vaccines very soon. And the CDC actually makes pregnant women, #1 high priority to receive those vaccines. So certainly if you're trying to conceive, we do encourage you to get immunized and to also have the individuals who surround you get immunized as well.
There are some vaccines that are not recommended in pregnancy, and that is mainly because they are made with live viruses, and there is some theoretical or real concern about passage of the live virus to the baby. So those vaccines include varicella and the MMR, measles, mumps, rubella. Those are not recommended in pregnancy. But again, the reason for that is not because they're damaging anything. It's because it's a live virus, and the concern is simply the transmission. So the COVID vaccines are not made with live virus, and so reproduction and pregnancy should not be impacted by that.
Right. We would recommend the MMR and varicella to be done prior to pregnancy, and COVID and the flu vaccine to be given at any time as soon as you can get it. And you're right. It was the New England Journal article that showed that miscarriages are not increased with the COVID vaccine. And it was an article in JAMA that was just this year as well that showed that for fertility purposes, women's fertility, men's fertility is not affected at all because of the COVID virus. They've also shown that, or the COVID vaccine, sorry, they've also shown that when you get the vaccine, it does not cross the placenta. However, they have demonstrated that babies, when they're born, will have a little bit of antibodies to COVID. So there is that antibody transmission, at least to some extent, which may give the babies a little bit of benefit. But there's absolutely no downside that's been seen at this point.
Yeah, I agree. A lot of the stuff that we talked about can be found on our website. And we certainly are happy to go over a lot of this information in consultations with you as well. So if our patients are watching, feel free to ask questions about natural fertility. It's not all just IVF and and IUI. We also do. We're happy when our patients conceive naturally as well. So we can certainly help with that. Is there other stuff that we think that we haven't quite covered yet?
I get a lot of questions about stress and if their stress levels are affecting their ability to conceive. And mankind is amazing. Women can conceive in some of the most physically and emotionally stressful conditions, but certainly reducing stress in your life is good for your health overall. And so if you can do some lifestyle modifications to reduce your stress, whether that be increasing exercise or spending some more time on self-care, we certainly encourage that. But if stressing out about reducing your stress is just creating more stress, then, sometimes we just have to move forward with the circumstances that we have and try our best.
And I think there's an app with Fertilcom that's put out by one of the pharmaceutical companies with and one of the therapists and providers from New England. Is that the name of it that you guys remember? That's really good about.
I think it's Fertilcom. I'm not sure that they're still doing it. Yeah, that's why I wasn't saying anything.
Okay.
Yeah, I think in terms of stress, it's hard because people experience stress in different ways. Sometimes the smallest things can really stress certain people out, and large things don't, and then it's really hard to deal with it and figure it out. I think that it's always good to try and make whatever lifestyle modifications you can to cut out stress. Oh, acupuncture is something we can briefly mention too. A lot of people ask about that. So the studies on acupuncture are interesting because studies comparing acupuncture to placebo do show an improvement in outcomes, especially around the time of embryo transfer, but not necessarily studies that are comparing acupuncture to sham acupuncture. So maybe it's the acupuncture. Sham acupuncture is where you're sticking needles into random areas, right? So it may be a complete placebo effect. It may be that the sham acupuncture has some benefit as well. So I think the jury's out on that. Certainly doesn't appear to be harmful. So I think that if it's something that's enjoyable, that, you know, go for it. But if it's not enjoyable, then don't do it. I don't think it's one of those musts. You know, there are some things that you should definitely do: prenatal vitamins, regular intercourse, right? If you're gonna, you know, if you're gonna decide between having sex or acupuncture, have sex. You know, that's much more likely to help you get pregnant than the acupuncture.
And I just looked up the Ferticom. It actually is the app is still up, and you can go into ferticalm.com and look at it if you want.
Okay, great. Yeah, I couldn't find it the other day. Maybe I was spelling it wrong. Okay, that's why I said that.
We have a question here regarding the COVID vaccine and the new booster shot that is being endorsed by our government. There has been, I'm going to read the question here. There has been talk about certain brand shots suggesting booster shots to high-risk people. Would we recommend a third booster during or before pregnancy? I think the answer is yes. I mean, the COVID shot has shown to be safe in individuals trying to conceive as well as in pregnancy. The bigger concern, I think, is actually getting COVID. And I know a lot of people stress about the vaccine. Our studies have demonstrated it is very safe, but I think the bigger concern is, you know, if you feel a little under the weather from the COVID shot, just think about how much worse you're going to feel if you actually get COVID, and that can't be. That would be worse than the COVID shot.
Yeah, I think we certainly are always concerned that patients who are pregnant and get the flu have a much worse outcome than patients who aren't pregnant with the flu. And COVID, you don't want to get COVID ever, but you certainly don't want to get it when you're pregnant and risk the pregnancy as well. I know that at Capilani there was just recently a baby that had to be delivered very early because the mother had COVID in order to save save both the baby and the mother, and at this time both are doing very well, thankfully.
We do have a question about breastfeeding. So if you can't conceive naturally and need IVF, is it hard to breastfeed naturally after giving birth via IVF? No, it doesn't. It shouldn't make any difference at all. In fact, an IVF pregnancy really is just a totally normal pregnancy. After the first trimester, where we're giving you some certain medications to help support the pregnancy, after that, it's just a normal pregnancy, and there's no reason that you would have trouble breastfeeding. There are some conditions that are associated with infertility that are also associated with issues of breastfeeding. So, for example, polycystic ovary syndrome is associated with issues with breastfeeding and also associated with infertility. So it's not the IVF necessarily, but kind of the issue that brought you to IVF.
And there's some fantastic lactation consultants if you find that you are struggling. I do believe fed is best, but certainly if you can breastfeed and are able to provide that to your child and want to do that, and there is help there if you're having difficulty breastfeeding.
All right. Well, thank you, everyone. Thanks, Dr. Fraterelli. I'm glad you joined us after the brief technical difficulties we had.
I apologize for that. Thank you for waiting for me.
Oh, we didn't wait for you, though. Oh, wait, another question. Okay. In regards to second pregnancies and IVF treatments, will a mother's diet and lifestyle changes be different than when she decides to do IVF, frozen embryo transfer, or second pregnancy? Any thoughts on second pregnancies when using IVF? I don't think that there's any difference there except for the time that has passed. And any complications that occurred in the first pregnancy. So now that you had your first pregnancy, we're kind of smarter and know more things about you. Alternatively, sometimes a first pregnancy, maybe you had a C-section, and now the transfer may be different, or it may be more difficult, or sometimes you had a vaginal delivery and the transfer is way less difficult. Sometimes maybe you ended up with twins and you realize that you don't want another set of twins. And so maybe now you insist, or we insist along with you, on transferring just one embryo. So there are lots of things that we consider and that you learn about yourself and we learn about you through the pregnancy, but there isn't really a major difference in terms of FET protocol or anything between an initial and second one. So, all right, well, thank you, everyone. It was so nice seeing you guys virtually and seeing your questions. Please do feel free to reach out to us if you need help conceiving or for other similar matters regarding reproductive endocrinology and fertility. And we'll see you next month. Do we have our topic yet for next month? I don't know.
I'm not sure.
Yeah, we'll figure it out and let you guys know. Okay, thanks. Bye.
Thank you, everybody.